Good afternoon. External DCR is one of the most important surgery for nasolacrimal duct block. And we all know that in chronic dacryocystitic cases, there is a block at the junction of sac and nasolacrimal duct. And this external DCR is still one of the most successful way of treating such cases. In this anatomically, we want to create a bypass of blocked NLD by making a fistula between lacrimal sac and nasal cavity. And functional goal is achieved by relieving of symptoms of epiphora, discharge, and recurrent inflammation, which we call acute and chronic dacryocystitis because of recurrent pericystitic, that is inflammation around the sac. And we all know about the anatomy, and sac rests in the lacrimal fossa, and this is the anterior crest. And we have to make a passage in the bone here, which is anteriorly, which is formed by maxillary bone and then lacrimal bone. And sorry. Cursor नहीं काम करता है क्या? This is the place where इसको full screen करके दिखा उसमें आ जाए. DCR is one of the most safe surgery because there is no fear of endophthalmitis. And this is one of the early surgery which one should do during the PG time. This is the place where we tend to make a passage between the sac and the nasal cavity. And we will be de-roofing this place from lacrimal bone and this frontal process of maxillary bone. And this is indicated in all the cases of primary and secondary NLDO and congenital nasolacrimal duct obstruction, which is not responding to other conventional treatments. But it is contraindicated in malignancy, atrophic rhinitis, dry eye, bleeding disorders, tuberculosis, rhinosporidiosis, and relatively in older age group where the tear film is less. And you should have a DCR set which has a bone punch, lacrimal probe, and punctum dilator, etc., which is a nasal pack, speculum, etc., and lot of gauze pieces and cotton and xylometazoline nasal drops. And patient should be on good control of blood pressure, and they should not be on any blood thinner. Nasal packing is done before the surgery with a ribbon of gauze piece pack, which is soaked in lignocaine and xylometazoline. We are not using nowadays adrenaline because that may cause hypertension in older age patients. And before we go into the direct surgery, we know that most of the surgery fail because of healing of that bony ostium and inappropriate location of the of the bony opening, that which may lead to some syndrome in which anatomically there is passage, functionally it is not working. So it's very easy. Incision is made at the anterior crest here, lacrimal crest, because it's easy to diagnose anatomically with the fingertip only. And another way of making incision is at around 8 to 10 millimeter from this medial cantha. but always 7 to 8 millimeter is avoided because there is angular artery and vein. And usually in adult cases, we use local anesthesia, which is basically lignocaine with adrenaline and bupivacaine. And I actually tend to infiltrate all the area of sac here, and we put injection at the junction of the inner and upper junction of the orbit, and from there I infiltrate those that xylocaine and lignocaine and bupivacaine injection with here in this sac area, superiorly, inferiorly, and behind, everywhere, so that it gets diffused. And there is anesthesia in the whole region. This will take care of all the nerves. And incision is at the most preferred incision for me is at the anterior lacrimal crest, J-shaped incision, right from the just above the medial palpebral canthal. You can feel it here with fingertip, and from there 8 to 10 millimeter below in J-shaped. And this incision is only skin deep, and if it starts bleeding, you can use cat's paws. That is going to give pressure over the skin margin. That will certainly reduce the hemorrhage. And then this medial palpebral ligament is exposed, and from here to here, then lacrimal, this orbicularis is dissected bluntly from throughout the incision, and then MPL is disinserted from the origin by 11 number of blade, and this disinsertion of MPL itself opens up the periosteum, and blunt dissection is carried out, and then periosteum is elevated throughout the area of the sac by periosteum elevator, anteriorly, posteriorly, inferiorly, and superiorly. A posterior crus of the MPL is not disturbed because that may change the contour afterward of that lid, and that will then, even if the anatomical goal is achieved, there will be epiphora. So this area here, the bone will be deroofed. That is, from here you start making a ostium with bone punch. This is lacrimal bone, and keep going here and deroof this and lower part of the nasolacrimal duct also. And so the anterior, it is till punch cannot be inserted between the bone and the nasal mucosa, and posteriorly till removal of the aerated ethmoid, and superiorly till 2 millimeter above the medial canthus. Inferiorly till the nasolacrimal canal is partly deroofed. And then this making flap in the sac is very easy, and you can put lacrimal probe and tent the sac, and with the help of tenting we can make either U-shaped or 2 vertical slit and then horizontal slit, and then this is cut, and this makes the sac in this makes upper flap as well as lower flap. You can cut the lower flap, and in the same manner nasal mucosa is also cut, and both the lower flap may be cut and upper flap can be sutured by 2 or 3 sutures, and this may be further attached with the periosteum so that this does not sag. And after that, the orbicularis is sutured with 60 Vicryl, which is followed by a skin with 60 silk. And bleeding is many a time a problem. For this, good nasal packing and assurance, and make the less use of, or rather judicious use of adrenergic drugs should be there. And while during this surgery, the wound may be a good pressure can also most of the time controls the bleeding from the wound, and you can also suck the wound from there. With this, I say